Hello, I'm Dr. Frank Trudeau, Associate Medical Director at AstraZeneca. Thank you for being part of our Symbicort Speakers Bureau. I am going to provide training related to presenting the slide deck entitled Reversibility of Airflow Obstruction and Lung Volumes in Patients with COPD, Considerations for Treatment. To start, I'd like to emphasize that the approved slides and speaker notes are meant to help you relay the most important pieces of clinical information to your audience. Speaker notes for all the content slides also contain a key point which helps drive home the key message. The slides must be used in sequence and the presentation must be used in its entirety. Any changes to this slide set must be pre-approved through the AstraZeneca approval process. During your introduction, please inform the audience that this is a promotional presentation sponsored directly by AstraZeneca and that there are no continuing medical education or CME credits associated with this activity. This presentation will be focused on providing background information on the reversibility of airflow obstruction in chronic obstructive pulmonary disease, or COPD. On the first slide, which is titled Definition of and Risk Factors Associated with COPD, the key point to stress here is that historically, COPD was considered a disease of irreversible airflow obstruction, while asthma was characterized as reversible. In several guidelines, which include those from the American Thoracic Society, or ATS, COPD is characterized by airflow limitation that may be partially reversible. It's also worth pointing out that cigarette smoking is the most common risk factor for COPD. Exposure to other inhaled noxious particles or gases, including environmental pollution, as well as genetic factors, sex, socioeconomic status, occupation, perinatal events, and childhood illness, recurrent bronchopulmonary infection, and diet are also risk factors for COPD. The last point to emphasize is that COPD is generally a progressive disease, especially if exposure to risk factors continue. However, early diagnosis and treatment is key. Non-pharmacologic and other treatments, such as oxygen therapy, lung volume reduction surgery, pulmonary rehabilitation, and smoking cessation may delay progression, improve symptoms, or possibly both. Moving on to the next slide, spirometry used to confirm a diagnosis of COPD. The key point to emphasize, as seen in the graphic, is that patients with COPD have diminished lung function, including reduced forced vital capacity, or FVC, and forced expiratory volume in 1 second, or FEV1. COPD is confirmed through spirometry with a post-bronchodilator FEV1 to FVC ratio of less than 0.7. Remind your audience that FVC and FEV1 are key lung function and volume measurements obtained during spirometry. Highlight that FVC is the total amount of air a person can forcibly exhale after maximum inhalation, and FEV1 is the amount of air exhaled in the first second during the FVC maneuver. Compared with healthy individuals, patients with COPD have airflow obstruction that limits the amount of air that can enter and exit the lungs, resulting from a combination of small airway disease and parenchymal destruction. The last point to reiterate is that these patients have diminished lung function, including reduced FVC and FEV1. Diagnosis of COPD is confirmed when a patient has a post-bronchodilator FEV1 to FVC ratio of less than 0.7. The next slide is titled, While Reversing COPD with Medication is Currently Not Possible, Reversibility of Airflow Obstruction May Be. Here, the key point for your audience is that in treating COPD, reversing the disease with medication is just not possible with today's treatment options. However, and this is critical, bronchodilators have been shown to provide reversibility of airflow obstruction. We know that COPD is a disease characterized by a progressive decline in lung function. We also know that reversing COPD with medication is currently not an option. Even though medication used to treat COPD have been shown to improve lung function and reduce symptoms, they have not been shown to reverse the disease or prevent loss of lung function over the long term. Reiterate for your audience that reversing the disease with medication is not possible now, but providing reversibility of airflow obstruction may be. Remind the audience that treatment with bronchodilators is critical to the effective management of symptoms in patients with COPD, and it has long played a role in the pharmacologic treatment of COPD. In addition, bronchodilators, through their effects on airway smooth muscle tone, have been shown to provide reversibility of airflow obstruction, improve lung volumes, and reduce hyperinflation. The final point to highlight is that bronchodilators are prescribed as an as-needed or regular basis in patients with COPD to prevent or reduce symptoms, depending on the symptoms of the individual patient. So, for example, short-acting bronchodilators can help reduce symptoms and improve exercise tolerance in patients with intermittent symptoms, while long-acting bronchodilators are more effective for alleviating persistent symptoms. This slide, How is Reversibility of Airflow Obstruction Defined, will help get your audience all on the same page. The key point to highlight is that guidelines from ATS define significant reversibility of airflow obstruction as an FEV1 and or FVC improvement of 12% or greater and at least 200 milliliters, whereas the American College of Chest Physicians, or ACCP, defines significant reversibility as an FEV1 improvement of 15% or higher. Your audience now knows that there is no clear consensus about what constitutes reversibility in patients with airflow obstruction, but now you can point out that the ACCP and the ATS provide guidance with regard to what entails significant improvement in FEV1. As shown in the graphic, the ACCP defines reversibility of airflow obstruction as an increase in FEV1 that is at least 15% above the pre-bronchodilator FEV1. According to the ATS, reversibility is reported as the absolute change in volume as well as the percent change from baseline so that the improvement can be understood in a clinical context. And according to these guidelines, reversibility due to bronchodilation is defined as an increase in FEV1 of at least 12% and at least 200 milliliters above the pre-bronchodilator FEV1. In addition to FEV1, FVC values of 12% or higher and at least 200 milliliters compared with baseline also suggest significant bronchodilation. However, the inclusion of a 200 milliliter increase in FEV1 constitutes a more stringent measure because it is difficult for more severe patients, that is, those with lower FEV1, to achieve. Have your audience consider a patient with COPD who has severely compromised lung function, such as a baseline FEV1 of 800 milliliters. After taking a bronchodilator, that patient's FEV1 values reach 900 milliliters, which is 100 milliliter improvement. This meets the 12% increase requirement for reversibility, but not the 200 milliliter increase requirement. Therefore, we must conclude that this patient did not achieve reversibility of airflow obstruction as defined by the ATS guidelines. Moving to our next slide, which is titled Study Demonstrating Reversibility in Patients with COPD, we introduce some clinical trial data. Here, the key point to highlight is that COPD studies, such as Uplift, demonstrate that reversibility varies widely in COPD and that most patients are at least partially reversible. In the Uplift study, nearly 6,000 patients with moderate to very severe COPD were evaluated to determine bronchodilator responsiveness. 80 micrograms of ipratropium was administered. After 60 minutes, 400 micrograms of albuterol was given to ensure at least near maximal bronchodilation. Post-bronchodilator spirometry was performed 30 minutes after the administration of albuterol, which occurred 90 minutes after ipratropium. Responsiveness was assessed using 3 different criteria: at least 12% and at least 200 milliliters of FEV1 improvement over baseline, at least a 15% increase in FEV1 over baseline, and finally, at least a 10% absolute increase in the FEV1 percent predicted value. The slide shows the magnitude of the bronchodilator responsiveness, which was greater than expected. Point out that more than 50% of patients met the ATS criteria for acute bronchodilator responsiveness, and approximately 20% of patients with very severe COPD met the ATS criteria for FEV1 reversibility. In addition, 49% of patients with very severe COPD showed reversibility based on an increased FVC, even in the absence of FEV1 responsiveness. Final point to make here is that these findings indicate that patients with moderate to very severe COPD in this trial were responsive to near maximal doses of two different bronchodilators, ipratropium and albuterol, which were administered 60 minutes apart. Our next slide is titled, Some Patients Can Change Their Reversibility Status Over Time. Here, the key point is that when followed up long-term after bronchodilator treatment, many patients initially classified as not reversible demonstrated reversibility over time. Focus on the data. A total of 660 patients with COPD from the pre-randomization phase of the ISOLDE study were followed to determine their long-term reversibility status. Spirometric measurements were performed after treatment with 400 micrograms of albuterol and 80 micrograms of ipratropium bromide via a large volume spacer at 3 separate visits. The graphic shows on the left side that out of 385 patients initially classified as not reversible, 213 patients, or 55%, remained irreversible throughout the study. The study also showed that of the 660 patients in the study population, 52% changed their reversibility status, either to reversible or not reversible during the study period. This slide is titled, Reversibility Varies by Patient and Bronchodilator. The key point to highlight is that patients with COPD demonstrate variable reversibility depending on the bronchodilator used. Results from a study of more than 800 patients with COPD showed that 73% of patients demonstrated reversibility, as defined by an increase in their FEV1 of 12% or more and 200 milliliters or more. Reversibility varied in response to different bronchodilators and by patient. Even though 91 patients, or 11%, showed reversibility when treated with ipratropium alone, 222 patients, or 27%, had reversibility with albuterol alone, and 280 patients, or 35%, reversed with both ipratropium and albuterol. The final point to make is that fewer than 27% of the patients in the study showed no reversibility to any of the drugs tested, indicating that the majority of patients might respond to one or another class of bronchodilators. Moving on, the next slide is titled, In addition to FEV1-FVC ratio, airflow obstruction can impact other key lung volumes. The key point to highlight here is that, in addition to FEV1 and FVC, it's important to consider other key lung volumes when assessing COPD, including inspiratory capacity, or IC, in relation to pulmonary hyperinflation. Be sure to review key lung functions commonly measured in patients with COPD during a typical spirometric maneuver, and those that can aid in determining the severity of the disease as well as response to treatment. These include total lung capacity, or TLC, which is the volume of air in a person's lungs after maximum inhalation. Inspiratory capacity, which is the maximum volume of air that can be drawn into the lung after normal exhalation. Residual volume, or RV, which is the amount of air left in a person's lung after maximum exhalation. And functional residual capacity, or FRC, which is the volume of air present in the lungs at the end of passive exhalation. It is the sum of expiratory reserve volume, or ERV, and RV. Again, compared with healthy individuals, patients with COPD have airflow obstruction that limits the amount of air entering and exiting the lungs, resulting in increased RV and decreased IC. Looking at the graphic, point out that the red line within the lungs represents air moving in and out. The smaller waves represent normal breathing, which is tidal volume, and the tall waves represent maximal inhalation. The wave that dips lower represents maximal exhalation. Describe how in patients with COPD, airflow obstruction leads to air trapping, which occurs during normal exhalation. Air trapping contributes to elevated RV and pulmonary hyperinflation, which in turn results in reduced IC. Moving on to the next slide. Hyperinflation worsens as COPD progresses and with exercise. Here, emphasize the key point that compared with healthy individuals, patients with COPD have hyperinflation, which worsens over time and with exercise. Bronchodilators can improve lung volumes and reduce hyperinflation. It's worth mentioning that as COPD progresses, several changes occur, including the loss of lung elastic recoil, alveolar and parenchymal tissue destruction, airway narrowing, and small airway inflammation. Underscore that these changes will affect a patient's ability to exhale, and progressively more air will be trapped in the lung, resulting in pulmonary hyperinflation. And as COPD progresses, hyperinflation of the lungs becomes more pronounced. Hyperinflation leads to the impairment of respiratory muscle function and gas exchange and increases the work of breathing. Note that during exercise, hyperinflation worsens. This further reduces exercise tolerance in patients with COPD. Finally, highlight that in several studies, treatment with bronchodilators improve hyperinflation, reduce the work of breathing, and improve exercise tolerance. Moving on to the last slide, understanding reversibility and lung volumes in COPD. The 4 points on this slide provide a summary of what was just presented. First, while reversing the disease with medication is currently not possible, ATS guidelines and clinical data demonstrate that airflow obstruction in COPD may be partially reversible. We've just seen studies showing that bronchodilators provide reversibility of airflow obstruction in a large proportion of patients with COPD. Reversibility status may vary in response to different bronchodilators and may change over time. Lastly, bronchodilators have also been shown to improve key lung volumes and reduce hyperinflation. Comments to AstraZeneca. Please read what is said on the slide. AstraZeneca is committed to conducting business with the highest standards of integrity and professionalism. If you have comments that could improve the delivery of our promotional educational programs, please contact AstraZeneca at 1-800-236-9933. Thank you.